Hello, and welcome to Curated Conversations, a podcast by the Grand Rapids African American Health Institute, where we talk all things health and wellness. My name is Ashley, and I will be your host for today's conversation. I am so excited to be joining you all again. It's been a while, but we have an amazing episode coming up for you all. We have Dr. Kathleen Jarrett here with us on today. Hi, Dr. Kathleen. How are you?
Hello. Good morning. Thanks for having me.
No, thank you for joining us. So we have Dr. Kathleen Jarrett, MD, is a highly respected board-certified internal medicine physician practicing in Grand Rapids, Michigan with Corewell Health. She completed her pre-medical studies at the University of Michigan, Ann Arbor, earning a Bachelor's of Science in Brain, Behavior, and Cognitive Sciences with distinction in 2006, a foundation that continues to inform her compassionate, informed approach to patient care. Dr. Jarrett earned a medical degree from Michigan State University College of Human Medicine and completed her internal medicine residency through Spectrum Health Michigan State University. Now she serves as the hospitalist physician as the medical director for Healthier Communities in Corewell Health, where she leads initiatives focused on advancing equity, strengthening community partnerships, and improving outcomes for vulnerable populations. She widely is recognized for her transformative work in sickle cell disease care, having developed and implemented a standardized clinical pathway to improve pain management, reduces hospital length of stay, decreases readmissions, and addresses implicit biases in clinical treatments. Her leadership has helped position Grand Rapids as a regional model for equitable sickle cell care and delivery. Dr. Jarrett's dedication to excellence has earned her numerous honors, including a Giant Eugene Brownie Medical Science Award in 2026, Best Physician in Nursing Excellence in 2024. That is nominated and selected by her nursing peers for her communication and rapport with staff, Sickle Cell Quality Award in 2024 for excellence in clinical delivery and improved length of stay, and Top Doctor in 2023 and 2024, selected by her physician peers. Through clinical leadership, community advocacy, and system-level innovation, Dr. Jarrett continues to advance high-quality, compassionate care while serving as a visible champion for health equity in West Michigan. Dr. Jarrett. Yes, I just want to give you your flowers and applaud you right now. That is amazing. Thank you so much for all that you do in advance before the podcast. Thank you for your work and your dedication.
Glory to God. Thank you.
So we are just going to jump right into it. From your perspective as a hospital physician, what is the current state of Black health in our community?
That is such a complex question, and I really had to think about that one because it feels like we're constantly under pressure as a people. Whenever we point out inequities in our healthcare, we're gaslit to believe that those things don't exist and it's in our head and just focus forward. Why are we looking backwards? But the repeat emergency room visits, the increased complications in their care, those are all symptoms of an outside of the hospital system that's broken. And the hospital really is a place when the system really has failed to catch them. So my thoughts on that are it's difficult for us to get primary care visits. It's difficult to afford insurance these days. It's difficult to afford the medications that are recommended. So, I mean, it's a complex issue. It has a multifaceted approach, and it's certainly something that we continue to have to invest in and think about.
Yeah, so you mentioned, like, the hospital failing. Like, can you give us some examples of, like, what that looks like and how it happens?
So when people are in the hospital, that's usually when I see them at their worst. So the objective is to catch people before they have to get to the hospital, and that's usually a symptom of our failure as an outpatient system, meaning outside of the hospital, to catch these patients before they arrive there. And that can mean anything from the ability to get an appointment, the ability to have time off from your job in order to go see the doctor, and even affording the medications that are recommended to us.
Yeah, so we talked about it a little bit. So let's talk about some of the social factors that impact the health of Black patients, like such as the access, the stress, the transportation. Let's talk a little more about that.
Absolutely. Well, transportation is certainly one thing with the cost of vehicles these days.
Yes.
We were thinking about purchasing another vehicle as a family, and we looked at those prices, and it's just astronomical.
Yes.
And can we really do that now when the cost of food has gone up?
Yeah.
My budget I have 5 kids that are living with me. it's just too expensive. And so we have to think about that realistically and what that means for our patients too, and meet them where they are. Some of the other concerns, you mentioned social things, is sometimes my patients, once they land in the hospital, will comment that their symptoms weren't taken seriously early enough. And that's kind of getting back to what I said earlier about being gaslit when we bring up things and say, well, I said that to so-and-so, and it didn't get worked up until it was too late. Or I really couldn't take off time from work. I'm in that 90-day probationary period. How am I going to get to you? You won't refill my medicines because I couldn't see you, but this is my blood pressure medicine. I really need this. And now they're in the hospital because they couldn't take off work and they couldn't get a refill because they didn't follow up. So it's a system issue.
Yeah, that even as far as thinking about having to choose between food and health, when kind of it goes hand in hand,
Right.
so being put in those type of situations and facing those type of barriers, can imagine that you all witness that a lot in the hospitals. So what roles does access to primary care and early screening play?
It's a powerful one. If I have, as a patient, the ability to see my doctor during a well check, I can catch things that are going wrong before I feel the symptoms of it. And oftentimes, people wait because they say, I feel good. Why do I need to go to the doctor if I feel good, right? And I hear that a lot. But it really is important, and most insurance plans do cover well visits. So that means that if you already carry a diagnosis of high blood pressure or diabetes, et cetera, and those are stable, you still go to the doctor, right? Because not only does that say you have follow-up, as I had mentioned before, that's key for needing refills in the future, but if things are going awry and you're not feeling it yet, say your blood sugars are starting to trend up, even though you're compliant and doing what your doctor said, they can catch and adjust your medications before you start to reap the damage of having uncontrolled blood sugar for too long. And that can mean kidney disease. It can mean heart disease. And those are the factors that really hit us the most.
So I kind of want to pivot to, let's talk about trust.
Oh, gosh.
I know trust in the healthcare system. We know that as Black people, we have a long, very, very, very long history with just not being able to trust. And it's important to note that I think a lot of it isn't necessarily that we don't care about our health, that we just necessarily want to suffer or that, but it's just, we just don't trust. Like we have an issue with trusting someone with our health. So to pivot, how does trust in the healthcare system show up in your patient's interaction?
That is
that could be with you or just what you've seen in general in the hospital, just anything.
Yep. I actually had a couple of thoughts on that. So we're digging deep here now. So going back to the Tuskegee experiment, that's what you're referring to with the long history of not being able to trust what's recommended to us. Those are all valid concerns. And we saw that arise right up during COVID when these vaccines were being recommended. And how do I know that they really have our best interest in mind? And in those situations, it's hard to navigate, even as a healthcare provider, when I'm hearing it from the government too at first. But trust is also powerful. That's a hidden vital sign, I say. Because when people are in the emergency room and you already have our president that's giving, unfortunately, this view or imagery of Black folks in a certain way that's disparaging. And then we're coming into a community. How do I know that the people that are taking care of me here in the hospital, how do I know that they don't agree with that too? And that's hard. And I think about those things, and I think about my patients that think about those things too. And it's very visible in how they see me when I show up. Let me backtrack a little bit. I had a patient a week ago, and they had a very complicated diagnosis. Unfortunately, I can't go into those details. But when I walked into the room, it's like their whole demeanor lit up. And this is a family of color. So when you see a provider or a doctor, physician assistant, nurse practitioner that's taking care of you, or even a nurse that's taking care of you that looks like you, it's easier to bridge that gap, right? Because now I know and I understand your lived experience, and I can take what you say at face value. Yeah, I feel those stressors too. I see, you know what, I did read about you telling so-and-so about that in your visit, and I hear you. And it's easier to communicate when I already feel like I have that bond.
Yeah,
right?
no, it's definitely an indication, and we can't say it enough how much representation matters.
Absolutely.
You know, I am much more likely to be put at ease and feel a little more comfortable, and not just comfort, but feel safer if I walk into a hospital or a room and I have someone that looks like me that is taking care of me, you know, because so many times in the past the system has failed us and dropped us and just moved on as if it were nothing. So that is such an important thing when you talk about your health, because a lot of times it can be scary and we're already facing maybe a diagnosis or something's going on. I don't know what's happening. Like, I'm not a medical professional, but when we have someone that looks like us, it just provide a little bit more comfort and safety. And I think that is something that we should be aware of more, you know, and something that we should put more emphasis on.
Absolutely. And that actually triggered a thought of communication. If I understand how you communicate and what our language is in our culture, it's easier to translate what I want you to do if I already understand your lived experience.
Yeah, no. So what does culturally responsive care look like in a practice from your perspective?
It's kind of a repeat of what I had said before, that it's adjusting my plan as a physician to accommodate you and your lifestyle, right? So if I know that you can't make it because you're in this 90-day probationary period, I will say to my nurse, you know what, let's do the refill. That'll get them past that 90 days. Or let's do a virtual visit. Yeah. We have had people that have done virtual visits on the job.
Yeah, COVID changed like all of that with the telehealth and everything.
Yes. So, and it's being bias aware. It's my body language. It's the words that I use. If you're talking about pain, it's actually believing that your level of pain is valid and not diminishing it because you're using your cell phone and saying, well, they can't be in, that much pain. Well, no, I believe you, and I'm going to help you in that sense. So.
Yeah, and I think that to the culture as well, it kind of goes into, like, if you're asking, like, on a pain, like, what's your pain level from 1 to 10? I'm just like, yo, doc, I'm at a million. Yeah. And not just to take that as I'm just exaggerating, but, like, understanding, like, hey, I need help. This is serious, instead of just like passing over it and dismissing it as just like, oh, well, it's not that bad. So I think that, understanding the culture and being immersed into, and just how we communicate, like it is different. That also plays a lot into it.
Yes, and I hear that from my sickle cell patients a lot, that chronically live with pain all the time. So when they're in the hospital, when they're saying a 10 out of 10 is, that's a big thing for them. So we got to believe them and meet them where they are. So.
Yeah. So even with the long history that we've had with Black people in the healthcare field and we slipped through the cracks, we've been forgotten, we've been dropped, and it just all kind of seems bad. It does play an impact on how we move forward. But can you provide a little bit of hope and talk about some of the improvements in the last 7 years that you've seen?
So I've had the privilege of being a part of some of those improvements. Some of them being, as we kind of talked about, the virtual care visits. During COVID, we established a program called COVID at Home, where we were transitioning patients from the hospital to their home a little bit sooner than we really would have done pre-COVID, that were still having breathing problems. But as you remember, during that time, the hospitals were swamped and the lines were around the doors, so we had to do something. So I was seeing patients from the hospital in their bedrooms instead of keeping them there. And then once we came out of the COVID era, we transitioned that program and called it Transition to Home instead, and we expanded our diagnoses to encompass other things like sepsis or infection, urinary tract infection, COPD, heart failure, things like that, where we're doing the same thing, where we're able to see patients in their homes and catch things before they start to flare up again, before their weight starts to go up when they're weighing themselves for heart failure. We can send medicines to them before they have to come back to the hospital, and that helps with our readmission rates. And for sickle cell patients, I've been able to standardize care for them, and we have found that standardized care eliminates bias or reduces it, because there's less variation from provider to provider, and we set a standard of expectation for everybody to follow. So you can't say, well, I didn't do X, Y, and Z because I didn't feel comfortable. Well, now that's the standard of care.
Yes.
And so patients are feeling like now they're being heard. Now they're getting the things that they've been asking for all along. And that kind of ties into patient experience, which our Joint Commission heavily weighs on. Our ability to listen to our patients and making sure that their pain is actually taken care of. That is a benchmark that we have to meet. So those are things that I feel resulted because we're listening more.
So what efforts inside healthcare systems or community partnerships do you see that are making a difference?
Things like this,
Yeah.
where we're actually in the community talking to folks
Yeah.
and explaining things and breaking it down, because medical terminology, it's like a whole nother language. I had to learn it. I am the first doctor in my family, on my side of my family. So learning those terms, like, I always go back to malignancy, the word malignancy. For the longest in medical school, I was afraid to ask questions because I didn't want to be viewed as quote unquote dumb. But that's how my patients have said too, like, if I hear these terms, I don't want to appear that way, but I also want to understand what's going on. And that brings me back to an important point. Don't be afraid to ask questions. This is your life, you know? And so not only are we meeting people in the community, but the community is a part of the solution. They are helping to tailor what we do next and helping to shape what programs that we make available for our communities so that we can engage them in more than just one way. It's not just a one-way directional street like it used to be, where if you got sick, you went to the doctor, but now it's bi-directional. We're coming to you and you are coming to us, and there's many ways that we can do that.
Yeah, and I love that. It kind of makes me think about how providing care just isn't within the four walls of the hospital. That you do have it's like church, that it extends, the church extends outside of the physical building. And I think that by doing that and coming on podcasts such as this one and providing information and your expertise, like, that is still saving lives and, helping to save lives. So I love that you say it like that.
Yes.
So what are some of the barriers that still exist today, and how can we combat those barriers?
Structural barriers. I don't read or listen to the news much, but when I do, I just feel depressed. So I'm trying not to. But the truth of the matter is, one of the things that I heard about is the administration is trying to limit the number of student loans for people that are extending to professional careers. I just told you that I'm the first of my kind to become a physician. I wouldn't have been able to do that had my loans been restricted. I think the cap they mentioned was $200,000. Do you know I got almost $400,000 in debt? I wouldn't have been able to finish.
Yeah.
And if we're saying that seeing someone that looks like me is important, not just in the African American community, but other communities, then we're really shooting ourselves in the foot if we think about it. So it's not only structural, but it's these silos that we're creating too. So in the city, it's easy to find healthcare, but when you exist in the rural areas where there are more communities of color, because it's hard to afford to live in these condos downtown, with gentrification, we've been pushed out. So we're in the periphery, and if we're not having the access that the folks in the city are having, then we're creating another barrier inadvertently, or maybe it was intentional.
Yeah.
So we have to think about it like that, from a different lens, and then figure out strategies to combat that. So that's why that bi-directional component that I was telling you about, where we're leaving the city and going to the rural areas, that's been helpful. And some of the projects that I've heard, like Cynthia Bell works with Native American patients and has a grant in order to bring healthcare to those rural spaces, where they actually bring a Corewell Health truck out there with Wi-Fi internet so that they can do virtual visits. That's innovation.
Yeah.
Isn't that crazy?
That's great.
That's amazing.
Yes. So where do you see some of the biggest gaps in healthcare outcomes?
Yeah. I would say the biggest bread and butter diagnoses that I see in the hospital are on our cardiovascular health. And that really goes back to what you were mentioning with the social factors with stress. Stress raises our cortisol level. If we're in a chronic state of stress, our cortisol levels stay stable and in a high form. So that means that cortisol level, while it's good for that fight or flight kind of mode, it's not good for your heart long term. It's not good for your body overall. So African American folks, we are 10 times more likely to see heart attack and stroke sooner than our counterparts. But how do we combat that? Part of it is mental health, and there's a stigma around that. So we really have to focus on destigmatizing and bringing joy to our community. And that's celebrating us in months like this. So unfortunately, DEI has been a taboo, and equity has been a taboo, but really that helps us bring together and actually share our culture with the community. And in that, we can all grow an appreciation for our differences. The other thing that I see, and I'm not a specialist in maternal fetal care health, but maternal death in the Black community is a huge factor. And unfortunately, that continues to be pervasive. That's a national emergency.
Yeah.
I think on Facebook, it was floating around in one of my doctor pages about a doula nurse practitioner who was a strong advocate that just passed away herself.
She was a midwife. Yeah.
She was a midwife and passed away herself. And that's really a shame. And me having my children, I unfortunately experienced the conversations and the complications, rather, of those things with low blood pressure, bleeding out, saying you're in pain and not getting believed. And this wasn't at this healthcare system, but it was at another that I was prior to moving up here. But those are real things that continue to happen, and unfortunately, it really has to be something that we do in a culturally aware way.
So I know you briefly mentioned that it's just the state of it. It's just kind of depressing.
Oh, yes.
With like the structural barriers and everything. So what gives you hope? Like, how do you find the hope to continue on and to continue to help these people?
That we continue to have these conversations, that we prioritize voting as a community, because if we can rally around, educate our community on its importance and how these decisions in the poll booth affect our health care, they're directly hand in hand whether we want to admit it or not.
Yeah.
So once we create space for these conversations and we are very intentional, I truly believe that we can see progress.
Yeah. Okay, so we've had such a rich conversation. I feel like this is a conversation that can go on for hours and hours and hours, and sometimes it needs to.
Yeah.
But so having said all that, are there any last messages for the community to hear about protecting our health?
Yes, we really have to prioritize us. If it means doing that virtual visit on the job, people are becoming more flexible and accepting that. Your health is your greatest asset. And I always joke, if I win the lottery, y'all aren't going to see me. But really, money only goes so far. I can be rich and in the hospital bed looking at you taking care of me. And that's not where I want to be. I would rather have my health and let that be my wealth. So that's it. I mean, that's the main thing. Your health is your wealth. So take time to write down questions if you have them. Just going back in medical school, one of the classes, I was the only Black student in this class, and they said that African American patients tend to be less activated. And what does that mean? Patient activation means that I understand what I take my medications for. I know what diagnoses I've been told I have. For example, diabetes. Do I have high blood pressure? And I know what medicines are used to treat those particular problems. That's what it means to be activated and engaged. And they also mentioned that we as a people don't ask as many questions. Well, let's change that. I was embarrassed in the room, kind of sinking down in my seat, and I was like, I'm going to go on the mic. This is why I prioritize this show, because I want people to actually know that that's what's being said to us, or said about us, rather, in these classrooms among physicians that are being taught and raised up. So let's change that. We have that power as a people to change the narrative. So I really believe that if we think about ourselves and our temple and what we put in it, more nutrient-rich foods. Yes, it is more expensive. I complained about that when I came off the Daniel fast.
Ooh,
but
how long did you do that?
Oh, girl, I only lasted 2 weeks. It's expensive. It's basically becoming vegan, and then you have to prepare all of your food from scratch. And I was on a 10-day stretch in the hospital of 12-hour shifts. I struggled. January just didn't meet up well with my hospital schedule, but I was complaining about that it's just too expensive to continue on like that. But I do think if we sneak that in there at least once or twice a week, we can start to reap the benefits long term. If we continue to prioritize chips or processed foods, I really believe that that's the reason why we're starting to see things like colorectal cancer popping up in younger people, or even strokes in younger people, is our diet is poor. What we put in our bodies, alcohol, smoking. I mean, you have to think about long-term what the impact is, and our body getting exposed to those long-term. They didn't have that back in the 50s, the processed foods that we did. They ate more from the ground. They had farms. So that's the biggest thing that I personally am noticing is a change. So I really believe that if we rethink things and how we pose foods for our kids, do we give them more cucumbers? Do we give them more carrots? Yes, that's how they learn what a nutritious food is. I remember I bought a bag of chips and my kids said, "That's not healthy, Mom." And I was proud of them because they held me accountable for it. But you know what? I hardly ever have chips. So for me, it was a rarity or a snack. But my kids held me accountable, and they see everything. So what we model has to be what we want them to live by in the future, because they will remember it, believe it or not. And my baby's 3, and she will hold you accountable.
Well, thank you so much, Dr. Jarrett, personally, just for being a shero, a hero walking around here and being a giant, trying to make a difference, but also making a difference and prioritizing our health. We appreciate you, and we hope that you continue to do the great work.
Thank you so much.
All right. Lastly, Dr. Jarrett, is there anything that you are working on in the community? Like, we're going to offer you opportunity to do a shameless plug. Anything that you want to let us know that you have going on?
Yes, so I work with GRAAHI on the Sickle Cell Task Force. It unifies all of our local hospitals and community centers. And last year was our first annual Sickle Cell Walk and Roll. It was a huge success where we had, I think it was 265 people for our first time ever. And we walked a mile around University of Michigan West. I would love to see everybody there, and I would love to have them part of that planning process. So that is what I'm working on now. It's one of the greatest things that I think that we've done as a system in order to prioritize our patients, because the patients, when they showed up, they said, "I never thought anybody saw me." It's a rare disease to have sickle cell, but to have hospital systems, not just one hospital, but multiple systems that are invested in this, and we're people of color. Oh my gosh, it was wonderful. It was remarkable. So it was great to have people share their lived experiences, their stories, and we were able to extract from that. And then we're going to bring forward those wins, and we're hoping to make it even better this year.
Yes, and there'll definitely be more about that coming up.
Yes.
And thank you all for tuning in to another episode of Curated Conversations. Happy Black History Month, and we'll see you soon.